This module is going to be going over lifting and moving patients. It's something that we do every single day at our jobs, but it's something that, if done incorrectly, can end your career. So it's very important to make sure that you are paying attention to how you do this. So our objectives here are going to apply principles of proper body mechanics, describe the importance of teamwork and communications, and differentiate among different calls for what requires an emergency versus urgent versus non-urgent move. For lifting and moving, you always want to make sure that you're using proper lifting and moving techniques whenever possible. Now, I realize there's going to be times when you can't because of the positioning of the patient, smallness of an area, or other things like that. But always try to make sure that you are doing it the best that you can. Right, before lifting, before doing anything else, make a plan with your partner. Communicate, talk to your partner, and whoever else may be helping you to make sure everybody understands what the plan is, which way you're going when you pick them up, how you're picking them up, and how fast you're picking them up. Right? Then make sure that you know your limit. It depends on your personal strength. For me personally, if I'm with a partner who's approximately as strong as I am, I can usually move up to about 350, 400 pounds with just a partner. Any more than that, or in some really precarious situations where I can't use proper mechanics, I'm going to need help. So don't be afraid to ask for that help. Lifting technique includes planting your feet shoulder distance apart. You don't want your feet really, really wide. You don't want them right next to each other. You want to give your legs room to work. You want to position your hands with your palms forward, and then you want to lift with your legs, not your back. You don't want to curve your back when you're picking up because you're going to not be able to engage your muscles properly. You're going to end up pulling your muscles and injuring yourself and or dropping the patient. And you never want to lean or twist as you lift if at all possible. You want to kneel, get beside the patient, move, and that may mean that you have to move that patient in several smaller steps instead of one big step. As far as our moves go, these are, a lot of people know what the differences are, but they don't always utilize them appropriately. Our emergency moves are for when that patient is in immediate danger if they remain where they are. So if they are in a car that's on fire and we need to remove them, if they're in a building that's on fire or about to collapse or whatever is going on, we need to remove them, and the danger from staying in place outweighs any danger of moving them immediately. So our different emergency moves are going to be an armpit forearm drag as seen in the right picture there. And you'll also see a shirt drag where you actually pull them by their clothing. I myself don't have much luck with this. It seems like I always end up trying to pull the shirt off of them. And then you've got your blanket drag or sheet drag where you put them, maybe log roll them onto a sheet or a blanket, or if they are already on one conveniently, you grab the corners of the blanket and you pull. Notice how in that picture he's kneeling down to pull. You want to try to do that if all possible. You don't want to lean over from a standing position and pull because you're going to end up hurting your back. The non-emergency moves are the ones that you see probably the most often, but sometimes they are done in emergency situations. The log roll. You know what a log roll is. You roll it aside, tuck whatever under them that you need, then roll them back, and then you've got your sheet or your backboard or whatever to move them. This takes a little bit of time, but it does protect the spine better when it is done properly. A direct ground lift. If we don't have any suspicion of spinal injuries, we can pick them directly up. Direct carry. This one can be precarious because people can be dead weight if they are unconscious or if they are just not able to help. And when they go dead weight, oftentimes they go limp as well, and that can be kind of like trying to hold up a really heavy wet noodle. Our extremity lift is probably one of the more common ones that you see along with the draw sheet and direct carry. Extremity lift is literally where you're just picking up their extremities and you're toting them around by those, or picking them up by their extremities. Now your urgent moves would be things like, say if somebody's in a car accident and you need to move them to get to the person that's pinned behind them that's not breathing. Well, they're not in immediate danger, but somebody else is. So this would be something like putting on a C-collar and then moving them to a backboard to remove them from the car, versus putting them in a C-collar, putting them in the KED, then removing them from the car to a backboard. So you still, basically a urgent move is a meeting point between your emergency and your non-emergency, where you're going to take some spinal precautions, but you're still going to move them fairly quickly. With our equipment, we want to make sure, first and foremost, that you know what equipment you're using. If you get new equipment, take a few minutes, get with somebody who's familiar with it, or the vendor, whoever brings it. Learn how to operate it. If you try to operate something that you're not familiar with, you could end up hurting yourself or your patient or your partner. You always want to make sure that you're using a power grip, which is the palms up position. You get more strength and grip strength that way versus palms down trying to pick it up. You also want to make sure that you're doing the kind of squat lift or power lift, and if you can see, it looks kind of funny in the picture there on the right, but your feet are about shoulder width apart, you've got your legs, you're keeping your back straight, and you stand up and lift with your legs, not your back. Moving patients onto the stretcher depends what technique depends on circumstances, where that patient's located. If they're on a bed, you can pretty easily get that even with the stretcher and use a draw sheet or something of that nature to move them. If they're on the floor, you're going to have to pick them up. So it just depends on where and how that patient's located and what condition that patient's in. If they're in cardiac arrest versus their toe hurts. And then we're going to want to make sure that we position the patient. Now, there's several different positions. Of course, you've got Fowler's position, which is where the head of the stretcher is up greater than 45 degrees. This is good for your non-critical medical patients. It's going to be easier to breathe in this position. It's going to give them a little more comfort if they're able to see around a little bit more. So typically this one's going to be more comfortable for your non-criticals. Now, semi-Fowler's is where it's, I believe officially is like 30 to 45 degrees, but it's somewhere between supine and Fowler's position. And this is one that a lot of patients prefer if they don't have respiratory distress. It's more comfortable resting position for a lot of them. The respiratory distress patients are not going to like this because it is going to make them feel like it's a little bit harder to breathe. This may also not be adequate for your bariatric patients, as that excessive weight on their chest can make it harder for them to breathe the more they recline as well. Your other positions are your recovery, which is where you are on your side there. You also may hear it called left or right lateral recumbent position. Make sure that if they are in this position that you can still secure them in with their straps and their rails. And then, of course, supine position, which is laying flat. Typically, you're not going to put a patient on the stretcher in prone position or knee chest position unless you've got some kind of OB emergency or something of that nature. But typically, you're not going to have your patients prone on the stretcher. When you're putting your patients on the stretchers, it's important to communicate with your partner, of course, but also with your patient. Let them know what you're going to be doing and how you're going to be moving them. A lot of patients don't like the sensation of being picked up and moved, and they tend to kind of reach out and they kind of panic a little bit and reach out and grab whatever's nearby, whether it be you, a rail, a wall, a bed, something. The problem with that is it interrupts our movement and our momentum. We can drop the patient. So we always want to make sure we tell them what we're doing. I like to tell them, give yourself a hug. You know, that gives them something to hold on to, or hold on to the belt or to the belt loops or something like that, that kind of gives them something to do with their hands other than trying to grab me or somebody else. Now, after you get the patient moved to the wheeled stretcher, you want to make sure that you cover them with whatever is adequate, whether that be a sheet or sometimes a blanket, and then you want to secure them in with all the straps. Make sure that you use all the straps. You should be using shoulder straps. They are very, very important. You want to make sure that they are putting the rails in the upright and locked position. If you use the equipment properly, it does its job. I had an accident many years ago where I was driving before I became a paramedic. And up until that day, we had shoulder straps on most of the ambulances, but we did not routinely use them for whatever reason. It was just like, oh, it just takes more time, the whole extra 30 seconds it takes to hook them up. And for whatever reason, on this wreck, it was one of the worst wrecks I've ever been to. And for whatever reason, that day on the backboard, we used the shoulder straps. We had him on the backboard. We put him on the stretcher. We secured him with the shoulder straps as well as the chest, leg, and abdomen straps. We got in a wreck on the way to the hospital. and our ambulance turned over. He was the only person who was still, him and myself were the only people that were still where they were supposed to be. Luckily, very fortunate, nobody else was injured in this wreck. But he, even though we were on our side, he was kept on the backboard, on the stretcher where he was supposed to be, and had no further injuries from that wreck. Use your shoulder straps. They work. Whenever you're moving your patients with your wheeled stretcher, try to make sure that you are pushing them where they can see where they're going, because that's kind of a weird feeling, not being able to see where you're going. So wheel them feet first if at all possible. When you're going down stairs, you want to take them down head first, and the reason being is that if you take them down, especially steep stairs, feet first, they can slide down and potentially off of the stretcher, whereas if you're taking them down head first, typically the head's a little inclined, they're less likely to slide and become dislodged or feel like they're falling off. When you are walking with the stretcher, look where you're going. Typically you want to walk with both people walking forwards, but unless you're going down steps or something and you have to walk slowly, try to use a spotter if you're having to walk backwards. Look for holes, divots, cracks in pavement, things like that can cause it to tip. Those wheels are not made for going off-road. Those wheels on the stretchers are not made to go off-road, and they will tip over in a heartbeat if you're trying to go through grass, wet grass, soggy grass, sand, gravel, they're not made for it. They don't do well with it. Also worth noting, pay attention to the stretchers. Learn the pinch points, because there are some places on there, if you put your fingers when you're lifting or raising or lowering that stretcher, it will cut your fingers off. So never grab anywhere where it says not to grab, and usually your red pieces make things move. Portable stretcher could be something like a tarp, essentially a tarp with a handle. It could be a small metal stretcher without the wheels, but just the framework of it. But these are made to go places where you may not be able to take a regular stretcher, or in situations such as an MCI or something where you're trying to move a bunch of people very rapidly. Your scoop stretcher is good for certain patients. If you cannot log roll them for whatever reason, if you can't access them, you've got this breaks them open, kind of like if you remember like the banana clips from the 90s, but it splits in half, and then you can literally scoop up the patient with it. You can put it on each side of the patient and slide it underneath them and connect the pieces. Just make sure, especially with larger patients, you don't pinch them in between those two pieces there in the middle. Now your long backboard, of course, it makes me very happy that we are getting away from the automatic response of car wreck backboard them, because the whole point is to preserve the spine in its natural curved state. We aren't flat like a backboard, we have curves, and these don't allow for that. That's why padding on a long backboard is super important if you're going to use it to utilize it correctly, so you don't cause any further injury or exacerbate what injuries they already have. Stair chairs, used for going up and down stairs. Of course, like everything else, there are some pros and cons, and there are some contraindications. For example, if your patient's unresponsive, you're going to have a hard time trying to get them on this chair. It's probably not going to work. So, they've got to be able to follow commands. They've got to be able to sit in an upright position. Obviously, you can't be doing CPR in the seat, things like that. But this could be a good option for moving patients sometimes. Your bariatric devices, now they do have bigger stretchers as well. The weight limit on most of the newer stretchers is going to be somewhere in the 700 to 800 pound range, but you oftentimes will find patients who they may not be over the weight limit, but they won't physically fit on the stretcher. So with these patients, a lot of agencies have special bariatric stretchers that are a bit wider or have a heavier weight limit on them, or you may even see these basically portable stretchers, which are essentially a tarp with reinforced handles that's designed to be able for a lot of people to pick them up and move the patient more safely for the patient and for the caregivers. Your neonatal isolettes. These are something that are going to secure onto the stretcher, or they may even have, as this one is, their own version of a stretcher. But essentially what this is a little containment unit for your neonatal infants, and these are used for transport in between hospital to hospital. Typically, if you're taking this, you're going to have either special training yourself, or you will have a neonatal nurse with you, and potentially even a doctor with you.